take home of this meeting would be we have to enhance the observational skills, and not all these acronyms has to come from the eastern coast of the United States, right? So anyway, we all know that Dr. Gass had staged 5 stages of group 2A juxtafoveal telangiectasias, and let's look into the multimodal imaging modalities and how does it really help them. So when you look into the stage 1, it's very hard to make a diagnosis of stage 1 unless and until we look, and obviously a diagnosis made in the fellow eye, and we'll be able to pick up the stage 1 in juxtafoveal telangiectasias. And the imaging modalities which are really of help is the autofluorescence, where you can see an increased hypoautofluorescence in this. And what does OCTA really show is this increase in the space of the vessels in between the vessels surrounding the foveal avascular zone at stage 1. In stage 2, what we can see is the loss of transparency or the perifoveal graying, what we all aware of. This comes in stage 2. And here is one observation which we have published a couple of years ago, where if you just look into the perifoveal graying with your indirect ophthalmoscope for a period of time, they tend to disappear and then reappear after 15 minutes of dark adaptations. So we had put in a different hypothesis, but that's beyond the scope of this talk now. And what we can see is on a fluorescein angiogram, we will be able to pick up the telangiectic vessels better on a fluorescein angiogram at this stage. Mind you, we are dealing with occult telangiectasia, not visible telangiectasias. Group 1 is visible, group 2 are occult telangiectasias. So in fluorescein, we're able to pick up most of them or on the temporal side. Some of them can also be on the nasal side of the fovea. And we can also pick up an area of hyperfluorescence which is more intense, possible due to the accumulation of the or from microaneurysms which can happen. And these changes are better appreciated on OCT angio. And on a regular OCT, you also see a lacuna or defect because there is a lot of neurotrophic damage which happens. And initially it happens in the outer retina, where you can see you have the photoreceptors which have got lost along with an ELM. Coming on to stage 3, along with the perifoveal graying, we also get to see you have the right angle venules, and sometimes you will be able to see a speck of hemorrhage, and these hemorrhage do not mean a development of neovascularization all the times. And what was just seen on temporal to the fovea can be involving all of the fovea when it comes to stage 3, and the dipping of the venules can be better appreciated on the fluorescein. And you can also see an area of hyperfluorescence which is a little bit more intense than the rest. It is probably due to the aneurysm, and the telangiectasias within the hyperfluorescence are better appreciated. You just have to see these lines which are a little bit more hyperfluorescent than the rest. And on OCT angio, one would be able to see the separation between the vessels which are more distinct in these stages in stage 3 compared to the rest. And most of these changes do happen in the deep capillary plexus. And on a regular OCT, you can see the ILM draping over the area where there's a loss of neuronal tissue, and then the outer retina dipping into the area of the retinal pigment epithelium, like what you can get to see here. Now, stage 4, one another characteristic apart from the perifoveal graying, dipping of the vessels, is the pigmentation. So RP hyperplasia, which happens, is so distinctly. The moment you see, you can make a diagnosis of stage 4, and mind you, these pigment hyperplasias need not have to happen only in the middle layers. They can happen in the inner retina. They can move all the way up superficially, and then they can be anywhere in between them as well. And now, on clinical evaluation, we can think this is in stage 4 disease just because of the pigment hyperplasia happens. And we all know that pigment hyperplasia usually happens, it engulfs the area where there's a dipping of the vessel. Now, if you do a fluorescein, what you can subtly pick up is over the area of the pigment hyperplasia, there's an area of hyperfluorescence which is a little bit more intense or seen better with the background hypofluorescence and the surrounding area of hyperfluorescence as well. So this is something which is different. So we are able to see a sort of a leakage which is happening. Is this stage 4, or on an OCT we are able to see a net? We are able to see vascular abnormality. So what we clinically observe as stage 4, on an OCT we are able to pick up make it as a stage 5. So this was our initial understanding a couple of years before when we started doing OCT in these patients. So how to identify stage 5 PFT? what we conventionally know of these two clinical pearls to identify stage 5 in PFT is an area of hyperfluorescence which is more intense than the rest, especially in the juxtafoveal area. That's one way by which we can pick up a clinical suspicion of a development of neovascular membrane, or an area of thickening in an OCT in a patient with juxtafoveal telangiectasia is a sure indicator of a possibility of neovascular membrane. So these two is the way by which we conventionally used to make a diagnosis of neovascular membrane once the clinical suspicion is there. But on OCT angiogram, it is able to pick up the neovascular net, and it is also able to pick up the telangiectic net. So we have these two types of nets which usually come in. And what we know for the literature which is being published in OCT angio are these three findings: the presence of abnormal vessels in the outer retina, then the dragging of vessels or the Medusa head-like appearance, and third is the increased space between the capillaries, which I already mentioned, which is usually in the non-proliferative, the stage 1 to 3. So these three findings are already there. So how to identify or how to fill in the gaps which we have in the in our understanding, and fill up the gaps, especially in relevance to OCT angio in the management of juxtafoveal telangiectasia, because OCT angio can pick up these abnormal nets. We have to find out whether they are really new vessels or not. So initially we had treated all these patients, and then when we found a way to put across a way by which we could delineate whether these are neovascular nets or not, we thought about two types. You have the type A and the type B. The type A is the neovascular net, and the type B is non-neovascular net. So the type B, the non-neovascular net, has these two characteristics. One is the terminal dilated bulbs, and then they are usually aligned along the course of the adjacent vasculature. And type A will have these three abnormalities, where you will see this encroaching of the foveal avascular zone, involvement of the outer retina, and bunching of the vessels. So these three would form the type A. Any one of the type A characteristics seen in type B also would make it type A. That is very logical. To just take you through a representative case, this is stage 4 on clinical observations. And if you see the OCT angio, we see a type B net here, because the terminal dilated bulbs and aligned with the course of adjacent vasculature. And in the left eye, again stage 4 in clinical evaluation, but if you do an OCT angio, we can pick up the abnormal vascular net in the outer retina that makes it type A, or the neovascular net. And if you use the right eye and the left eye separately, you can see the changes in the right eye. In the right eye has not been substantial after injection with anti-VEGF compared to what you can see in the left eye. So the results of our patients, we had about 12 eyes, and with an anti-VEGF injections of 3, what we found that there was a visual improvement of 0.38, especially in the type A nets or the neovascular nets, compared to the type B nets. And these are just the pre-treatment and post-treatment images of especially patients who are with type A nets, and you could see the changes pre-treatment and post-treatment on OCTA. So to discuss, or I would say so all type A nets showed decrease in the size and or intensity post anti-VEGF therapy, and change in the size of type A net was seen in all patients with improvement in visual acuity as well, whereas the type B did not show any change in the shape or size of the net. And OCTA can play an important role in making early treatment decisions or wise decisions, and treatment based on the presence of type A net on OCTA results in significant visual improvement. So at the end,